Good morning, everybody. This is Dr. Michael Richman, and I'm with my friend and colleague, Dr. Fiorillo.
Good morning.
And we are so excited because, like I said, we've done some podcasts already, and we've touched on heart disease and seed oil. And yes, we're going to do a lot of topical things. But to me, our goal, and two doctors tell the truth, is ultimately, can we make an impact and can we save your life? And today we're going to do a two-part podcast. And today we're going to talk about the newer screening tests for cancer. One of them is FDA approved, and two of them are not FDA approved. Specifically, we're going to be talking about the Galleri test, which is a type of blood test, a whole body MRI. We're going to reference Preventative, and then Cologuard, which everybody knows is on those commercials and is embarrassed about. Poop box and send it back, hoping your UPS guy doesn't know what's in it. But and then our subsequent podcast, which will be next week, will be on what is standard guidelines for mammography, for colonoscopy, for prostate cancer screening. What is time tested, proven, and accepted? And I'm excited today, and so is Mike, because as we're both board certified general surgeons, before I became a cardiothoracic surgeon and before Mike became a plastic surgeon, we know this stuff, and we're providing you now with real medical information, right?
Yeah, and when I think about wellness and I think about what we're trying to do here and cut through, like we said originally, cut through all the nonsense and try and give you stuff that really works, people tell me all the time, hey, I'm going for a full body MRI, or hey, I just did this blood test, it came back negative, I don't have cancer. And we started with heart disease, why? It's the number one killer, right? We hopefully helped you a little bit understanding your heart and lipids and tests and that stuff. Now we're going to move on to cancer. That's the number two killer.
Right, exactly.
And I think just like you said, 1 in 3 plots in the cemetery is someone died from heart disease. I think we all know someone who's either had cancer or has died of cancer. So what can we do screening-wise to help figure out if you should be doing these tests? Not the preventative, and we'll touch on a little bit more about that. We already covered a little bit with fasting, but we'll try and basically go into these screening tests. And I think the first one, why don't we start with the Cologuard, because that one is FDA approved.
Okay. Yeah.
And that's a real interesting one. So
Right.
you want to kick it off with Cologuard?
Yeah. Okay. I just want to give just some statistics just because I think it's important. So in 2024, there were, so far the data is 2,001,149 new cancer diagnoses. Okay. And the deaths were approximately 640,000. Okay. And like we said, there are 900, just under a million cardiovascular deaths. Cancer is still substantial. So 640,000 people are dying a year of cancer. And the number one cancer deaths in both sexes is lung cancer. Okay. It's not the most, in women, breast cancer is still more common than lung cancer, but the number one killer is lung cancer. Okay. And colon cancer is right up there. So Cologuard is an FDA approved test for people over 45 who are at average risk.
Yep.
And what does that mean, average risk? Average risk means you have no family history and you have no, as Mike knows, there are diseases that predispose you. So if you have ulcerative colitis, predisposes you to colon cancer. Or if you have a familial syndrome, in other words, do you have what's called familial polyposis, which is multiple polyps in your family? Okay, so a person who is at average risk, Cologuard. And what they're doing is basically they're checking your poop. You're giving a poop sample for tumor DNA and blood. And it's phenomenally accurate. It's been validated in multiple clinical studies, and we'll give you numbers in a sec. So Cologuard, to me, just so you know, according to guidelines, say for traditional colonoscopy, your first colonoscopy, unless you have one of these high-risk situation, it should be at 45.
And by the way, they lowered that too, right? So it used to be at 50. They lowered it to 45. And I will say, my brother's a GI doctor, so we talk about this all the time. He's seeing it in younger and younger people.
Oh,
and this is something, and I know a few people that died from it, unfortunately, young. And this is something that could be preventable, could be caught early.
Right.
So the earlier, the better you get tested. 45 with no family history, get it done. And the colonoscopy, everyone's afraid of it for some reason. I get it, right? But I've done 2 of them now. It's not bad. The prep is so much easier than it used to be, and little twilight anesthesia, and done.
But
So I would not put.
we'll get in. I think we'll get into more of that on Monday. But or yeah, Monday, I guess it is. But today, I just want to really more focus on the Cologuard.
Correct.
And so insurance pays, I've had 2 of them. Insurance pays, and they're done every 3 years, as long as they're negative. Insurance pays 100% for them if you're above 45. It's an accepted screening test.
Yep.
But I also think Cologuard is not expensive. Let's say you're under 45 and you're just a worried person and you're low risk. Remember, if you're low risk, yeah, I think you can have it done.
Yeah.
Okay. So there's a new Cologuard Plus, which is phenomenal. Cologuard, aside from picking up cancers, and the numbers, I can give you the new Cologuard Plus numbers because Mike and I believe in precision. So the Cologuard Plus, so in all stages of 1 through 4 colon cancer, the true positive rate is 95%. The true negative rate is 94%. So colonoscopy, the true positive rate is 95%. Okay. So basically, it's as good as colonoscopy for low risk people. Okay.
Yeah, it's a great
Now,
test.
yeah, so those are people over 45. So now if you take the subgroup of 45 to 59-year-olds, remember, of all ages, it's 100% sensitivity. So in other words, if it's positive, you have colon cancer. Okay. And the negative rate is 94%. But what's great about the test is it also can find high grade dysplasia, which is precancer,
Yeah.
in 73% of people. So if it's positive, 73% chance you have a high grade dysplasia. And if it's negative, you can count on a 87% that you don't have high grade dysplasia and a 99% that you don't have cancer. Okay.
What are your thoughts on someone that is just, because I know a lot of people like this that just don't want to get a colonoscopy at all and they're just doing this test. Would you say at some point you need at least one colonoscopy?
Yeah, my personal opinion. So I just had one a couple months ago, and mine was, and I think people need to know is, I think as surgeons, it's not that we're ignorant because we know it's more out of fear because, to be quite honest with you, like nobody's gonna bullshit Mike and I. Like we know, nobody's gonna say to you or me, don't you agree? If you have stage 4 colon cancer, all is gonna be well.
Right.
So doctors are horrible because it was like, I don't want to know. I've had 2 negative Cologuards, 3 years apart. I'm good. I'm good. My fear is that we're seeing, Mike and I aren't old, but we're seeing colon cancer now, advanced stage in 20-year-olds.
Yeah, it's getting younger for some reason.
Do I think everybody, I think that if you ask Mike's brother and you ask guys that are colorectal surgeons, they're down for Cologuards every 3 years, but they
Yeah,
also think
you should get correct.
if you have a negative colonoscopy, guidelines say every 10 years. Okay,
Correct.
that's guidelines. I don't know, but I think in the interim, I would feel comfortable getting Cologuards every 3 years
Yeah, you know
during
what,
those
and
10 years.
I totally agree with that, and we agree on that. And I think common sense would dictate get your first colonoscopy at 45. Can it pick up some other stuff that Cologuard can't, like diverticulitis or any sort of diverticulosis and any sort of abnormalities, and maybe a polyp that a Cologuard wouldn't pick up? Yes. And then they tell you, okay, you're good, come back in 10 years. And if you want to be more of a preventative person and you say, okay, I'm going to do 2 Cologuards in between, I think that's reasonable. And it's an
I
FDA
think that's such great advice because at the
yeah.
end of the day, Cologuard's been validated. They have the Cologuard Plus. If it's negative, you can feel good on this that it's negative.
And
Okay.
FDA approved,
All
covered
right.
by your insurance. So basically, we're fans of Cologuard and we support it.
Correct.
All
Okay.
right, next topic.
Next topic, Galleri. So Mike and I have different feelings. Galleri is a blood test, and what it is made by a company called GRAIL. And what it is it's a blood test where they're looking for 50 different types of cancer by detecting circulating tumor DNA. So in other words, the premise is that tumor sheds DNA, and by checking it in your blood, you're going to be able to pick up cancer early. Now, remember, all this stuff, it's not preventative, okay? It's for early detection. Okay, the only thing
Correct,
that's
and it's not,
preventative,
and is not FDA approved.
right? The only thing we just talked about with Cologuard, Cologuard does have a preventative aspect because it's going to pick up a certain number of, sorry about my golden retrievers, guys. It's going to pick up a certain number of pre-malignant cancers, polyps in the colon. Okay, so this stuff is strictly not preventative, it's early detection. Okay,
Yes.
so what are your feelings about Galleri from a standpoint of should people have it? And if you think they should have it, what are the limitations in your mind?
I'm on the fence on this one, not just because it's not FDA approved. Yes, we want to detect cancer early, but I think there's some things you have to understand with this test. So this particular one is $950, so there's a cost there. If you don't, if that's an issue, there's a cost. It's not covered by insurance like Cologuard. The other thing is,
Tell people why that is, though.
it's not FDA approved.
Right, but I think it's important to tell people why is stuff not get FDA approved, and it's because there is no robust evidence to show that it works, and it hasn't been validated in clinical trials, specifically with the Galleri, and then I'll let Mike finish. The initial trial, which I'll talk about, was conducted by the company, and you always have to be
Yeah.
leery of
Right,
studies
right.
that,
A paid study. Here's the thing too. I'm all for early detection, like we all are, right? So
right,
you'd say, wait, great, this is a great idea, right? Let me take a blood test, and if I catch something early, right? We're all scared of pancreatic is the big one. They're all big, but let me catch it early, right? I'm all for that. However, if you're going to do this test, you have to understand that there's issues with it. For example, the false positive and the false negative. It's not extremely accurate picking up an early stage cancer. So you could fool yourself and have a sense of false security. Hey, I did the Galleri, I'm good. And then maybe not follow up. Time gets away from all of us. And then 2, 3 years later, you're like, oh yeah, I
right,
did a Galleri, I'm negative. You forget it was 3 years ago, like we all do. You forget when you had something done. And then something's growing in there and you're going to ignore it. You might have a pain and say, oh, it's probably nothing, I did a Galleri. So that's one thing. The other thing too is the false positive.
yeah. So you want me
So
to say, so the trial that gave everybody pause. So this is technology that is established. So if you have a solid tumor diagnosed, a good percentage of solid tumors, the standard of care is what you get, which is called a liquid biopsy. The found a company called Foundation One does it, or Guardant. In Guardant 360, it looks at 360 genes, and that's for people who've already been diagnosed with cancer.
right.
And it's to see, do you have an actionable mutation? In other words, do you have a mutation that you would use targeted therapy, or do you have, you hear on TV with Keytruda, like they mentioned PD-L1. Do you have PD-L1? Do you need immunotherapy? So it tells you what subtype you have, and then it guides therapy. Okay, that's standard of care. Now, that doesn't mean that everybody gets it, depending on where you live in the country. So this is doing it. It's a liquid biopsy looking for circulate, and then they use an AI generated model. So the trial, which kind of blew it and gave everybody pause, was called Pathfinder, which was done by GRAIL, paid for. The false positive rate was 62%, way unacceptable.
Yeah, it's very
And
high.
and the true positive rate was 38%. Okay, way high. Okay, so
A lot of
so
unnecessary anxiety is going to come with that for sure.
and
And
downstream
tests.
testing
And
and
tests.
downstream testing. So unnecessary testing. Mike knows, so let's talk about it. The data shows that let's talk what cancers. It's not going to show blood cancers or it's not going to show lymphomas or things like that, but everybody worries about pancreatic cancer. And with advanced stage pancreatic cancer, tumor DNA is only found in the blood, even with GARD at like 30 something percent of the time. So with early stage cancer, and most early stage cancers don't shed tumor. Okay.
Right. Not going to pick it up.
Okay, so the point is to pick it up early. So let's say you have a Galleri test and it says negative. I just told you what the true negative rate is. Are you going to feel good? And the answer is no. You're going to say to
Right.
yourself, I don't know if I have early stage cancer. I have no clue if I have early stage
Correct.
cancer. So then they went on to do what was called the Strive study, and which is really weird to me. There were 100,000 people enrolled, and the completion date, which was in 2022, but the final completion date was in April of 2024, and they didn't report their results, and there's nothing. When it was done by GRAIL, which is telling you this is different than being done at Columbia or UCLA or wherever, Mayo Clinic, where they're going to report the data
Either way.
true or false. The company can keep the data quiet, so they haven't published a thing. There's no.
I kind of feel like it's an exciting field, and I'm hoping that this is going to be the future. I'm hoping they're going to be able to go in and get a blood test and feel really good about it. It almost seems like they jumped the gun a little bit. And when people ask me, should I do it? It's hard for me to say no, because has Galleri probably saved someone's life somewhere? Yeah, it probably has. But is it a really super accurate and great test? No. So I think you have to know that going in, that you could lead to a lot of unnecessary anxiety, unnecessary testing, and it could also give you a false hope that, hey, I don't have cancer, and maybe you do. Maybe you have a cancer growing in your body, and the Galleri did not pick it up. So, listen, if you want to spend the $950, I'll never tell you not to do it.
But let's talk about, though, like upstream costs. So let's say, as we just said, you have
so you go in, you do it, and it comes back positive. You say, shit, I might have pancreatic cancer. Now you're flipped out. You're thinking you're going to be dead in 6 months. So now, what do?
Sure. Remember, insurance isn't going to approve anything, okay, on the basis of, oh, I have a positive Galleri, because it's not even FDA approved. So for the
now you're going to go see a cancer doc or GI or whoever, right? And they're going to do what?
He's going to tell you there's no basis, okay? Doctor, I want something done. Okay, then I'll order you a CT scan of your abdomen. You're going to have to pay out of pocket. Now, your average person can't afford it. And let's remember, there's data out. I just wrote a paper on it. Repeated CT scans, actually, there's 93,000 cases of cancer diagnosed each year from unnecessary CT scanning. Okay. So are you going to go get a CT scan of your abdomen just because you have positive Galleri? No. You may say yes, but it's not practical. Are you going to go get an ultrasound of your abdomen? I guess that's fine. It's cheap, but you understand what the point is. This could be thousands of dollars out of your pocket and a road to nowhere, and the anxiety level is through the roof.
Yeah, for sure. For sure.
So
now couldn't, but potentially still has a certain degree that there could be something there. You could potentially save someone's life. So that's the hard part I have, is not telling someone no. So someone went, and it turns out they did have a small pancreatic cancer in their pancreas, and it was found and somehow resected, and they were cured from it.
But still remember, it doesn't justify, like, one person. If advanced, and we're just taking pancreatic cancer here, okay? But
unless you're that person.
But if you have an advanced cancer, stage 3 or stage 4 pancreatic cancer, where you're done with anyways, you're already having symptoms. You're not getting the Galleri. But if it only sheds tumor 34% of the time, I can't give you a number, but in stage 1 or stage 2, maybe 2 or 3% of the time. Okay, like, to me, it's not an acceptable test.
Yeah, it's not a great test, but I'm struggling because I know a lot of people that do it every 6 months, and I'm struggling to tell someone don't do it. I really am, because as long as you know all this we just told you going in and you're fine with it, okay, and you have the resources, then do it. If it makes
Right.
you
And
feel
if you
better.
can deal with the anxiety, and that doesn't mean becoming dependent on Xanax or Ativan to get through the
Yeah.
next year or two, because you can't deal with the anxiety and you become some maniac, like on this never-ending quest to find out what it is. Because believe me, there are plenty of cancers, and Mike and I can tell you that we never find out the primary. Okay, they have metastatic disease, they have stage 4,
Yeah,
and
that's true too.
and we can never find out the primary. And it's like it'll come back the pathology of a lymph node GI cancer. So we know it's somewhere in the GI tract with all these limitations. So I'm not a Galleri guy. I think it's too soon.
But it's
Um,
exciting. It is exciting, and I think
oh
it's
yeah,
only going to get better. It's going to get
right.
better with
Agreed.
AI, and it's going to get better. I think they jumped the gun a little bit, but it's here, and no buyer beware, like we say for other stuff.
Right.
Good. All right,
Okay.
good. I think we did a
So
good job on that. And okay, our last one,
our last one is whole body MRI.
which is very interesting to me as well.
Yeah.
Because I
Yeah.
also know a lot of people that do that as
Right.
well. And there's a lot of companies out there now that do this. Dr. Richman, should I go and get a full body MRI?
No. So first, I'm just using Pronovo because they have a lot of money. So they've done tremendous marketing. They've hired a lot of celebrities. They've offered me actually, if I would be a spokesman, being a double board certified surgeon, to get a free one. And if I promote it, and I just can't. So let's talk about whole body MRI. What are the limitations? So whole body MRI, just remember, this is just a screening test again. It will miss the majority of breast cancers,
Correct?
okay, especially if there's dense breasts. It will miss most thyroid cancers.
Correct.
Now, am I that concerned about thyroid cancers? Not really, because the majority of thyroid
High
cancers
cure rate.
are curable
Yeah.
or treatable. It'll miss the majority of colorectal cancers,
Yep.
okay?
Skin cancer.
It'll miss the majority of esophageal cancers,
Skin.
diffuse gastric. It'll miss melanomas on the skin,
Yep.
okay?
Lymphoma,
Metastatic.
leukemia.
Exactly. Unless you have the reason why it's not FDA approved, because there's currently no robust evidence to support its use. And this is from good clinical trials. There's no robust evidence to support its use for routine screening. Okay. And what we're going to talk about now on our next podcast, the US Preventative Task Force says you want to do stuff where there's robust evidence, you do mammography. If you have an extensive smoking history, you do low dose chest CT scanning every year, you do PSA testing, and you do colonoscopy. And we're going to talk about those, okay? Because there's robust evidence. And and furthermore, this will miss early small prostate cancers. Okay. So we've given you a bunch that it'll miss, because even though guys are like, no, I heard MRI, the prostate is fantastic. It's a different type of MRI. It's called multi-parametric MRI for prostate cancer.
Right.
Okay. So for all those reasons, again, it's expensive, but it leads to an unacceptably high level of downstream testing. And
And we can
yes,
say, and we can say the same thing with that we just said on the Galleri. Anxiety. Okay, so you pick up a 2 millimeter nodule in your lung, which is a good chance it's benign and it's always been there, and now you're like flipping out. You might have to get a lung biopsy or further testing on that. So that's a problem as well. That's the same thing we talked about before, right?
yeah, this kind of troubles me. So this is imaging. Okay, so you can see it. So let's I'll give you two examples. And Mike, you have a little teeny solid tumor in the head of the pancreas. I'm not going to get into it, but there's something now that's accepted. We have out here at USC and Hoag Hospital in Newport the largest registry of what's called IPMNs, which are intrapapillary mucinous neoplasms of the pancreas. And they're actually being picked up more. And we used to do surgery automatically if you see. So it's a little tumor connected to the duct. We used to do what's called the Whipple procedure or a distal pancreatectomy. Automatically, the majority of them are benign
It's a
or high
massive
grade.
surgery. Massive.
Okay, massive surgery. So you see a little teeny tumor there that most of them can be needle biopsied, but let's say this one can't be. Okay, let's say it's in a place where they just can't get to it. Are you prepared to sit with yourself that good chance it's not pancreatic cancer, slight chance it may be, or are you going to go have a Whipple, which affects the quality of your life forever, and find out it's benign? I'm not. Are you?
No, no, and that's the limitation of this as well, right? So I'm more in the wellness space than you are. So people ask me all the time, and I know a lot of people doing this, right? So once again, cost about 2,500 from what I've seen. I've seen up to 4,000, but I think 2,500 seems to be where it's at. And then false negatives and false positives. And the thing that always got me on this is I do it, okay? So I go in, I get it done, and then I leave there. I don't think I'm feeling as good as I should because you think, okay, they didn't find anything. Okay, what happens if one, they miss something, or two, it starts growing? Like the day I leave, the next day it just
Right.
starts growing. And I'm saying to myself, okay, because everything else, right? When's the last time you ever look back and say, oh, when's the last time I did something? And you look back and it was 2 years ago and you thought it was 6 months ago. Now all of a sudden you're ignoring something because you say, oh, I had a total body MRI, there's nothing there. Is a false sense of security as well. And you still need all the other tests. So once again, for me, when I tell someone don't do it because has it saved someone's life? Yes, I'm sure it has. I'm
Right.
sure.
Absolutely.
Yeah, so I'm sure they picked up something and hey, saved my life. Okay, that's great. I love it. So for the 1% of chance, there's no radiation. If you're okay paying the fee, then go ahead and do it. But once again, just like the Galleri, understand that could have missed a lot of things, and you can't be 100%, of course, as we said, but also it may lead to costly tests and unnecessary surgeries, which it has too. So you have to put this.
And it misses the number 3 colorectal cancers, so you're going to still need a colonoscopy.
Yes.
Like we said, it's going to miss breast cancers.
Your mammography.
Regardless of, I know we hear a lot of people who have pancreatic cancer. It's increasing, but it's still considered a rare disease. Okay.
Yeah.
There's what I tell you, like 63,000 new cases of pancreatic cancer a year in the United States. It may sound like a lot, but that's not a lot. Okay. That's not a lot of cancers.
It's a lot if you get it or your loved one gets it, of course.
Exactly.
That's what makes this interesting. Listen, here's the bottom
Well,
line.
the other thing is, I don't know. I never looked this up. So MRIs, there's newer MRIs that you can go in if you have foreign bodies or if you have a pacemaker. So in other words, if you've had an artificial hip or you have something metallic, a heart valve, you can't go in an MRI, and you see how they always ask you.
Yeah.
Or if you have a pacemaker. I don't know if these whole body MRIs are, you're able to go in if you have a metallic foreign body. I didn't look at it. I'm thinking no. Okay,
Probably no, correct.
because there's not a lot of places that do have those machines. They're becoming more
Yeah.
common, but they're
Yeah.
using it.
But here's the bottom line, right? These tests are available, and we can get them ourselves, right? We're doctors. I have not done any of the three, so I haven't done Cologuard, although I would do it, but I get colonoscopies regularly. I haven't done the Galleri, which I could definitely do. I could just, the rep's been in my office, right? So I easily could have said, hey, let me give you one. And I haven't done a total body MRI. I don't know. These are three things that I could do, and I haven't. And it's not that I'm just too busy or negligent. I just don't really feel I need to do it. Now, I have a lot of friends and patients that do it, and I have no problem with it. But I explain to them what's going on with it. How about you?
I do think what's more justifiable. So, for example, BRCA2, women know what BRCA1 is. Okay. BRCA gene is a tumor suppressor gene. In other words, it prevents tumor from growing. So if you have a BRCA mutation, meaning that suppressor gene is defective and allows cancer to grow. So BRCA1 is associated with breast cancer.
And we're going to do it. We're going to definitely do one on breast cancer, for sure.
Breast cancer, colon cancer, ovarian cancer. So BRCA2 is associated with pancreatic cancer. So let's say you had somebody that had breast cancer in the family or ovarian cancer, and they happen to have BRCA, okay? And then you went on to have genetic testing, male or female, because they test for BRCA1 or 2, and you have BRCA2, and you had a relative in the family that had pancreatic cancer. I think then it's completely acceptable, if you wanted, to have an ultrasound of your, we call it right upper quadrant,
Yeah.
pancreas and everything like that, or have a CT. I think then, but I still wouldn't go get a Prenovo
Right.
because,
So basically, I told you what I do for you as well. You said you've done Cologuard. You haven't done the other two tests, correct?
well, correct. No,
Okay.
no.
All right. So
And
that's
I,
where we stand. So Dr. Richman is pretty much a no on those, on the Prenovo, MRI imaging, and the Galleri. And personally, I'm a no. However, I will not tell someone not to do it. And
right.
if you want to do it, listen to what we're saying, understand that, and then have at it. Yep.
And I think Mike and I are always available for questions as long as we're not inundated. But I think that the best thing to do is, if you have any questions about cancer, is to really talk to an oncologist. And the one thing I always tell everybody, short of a big hospital system, if you want to know like the real fact, there's 72 approved NCI, which is National Cancer Institute, cancer centers in the United States, in 36 states in the District of Columbia. And you always know you're going to get the standard of care. So
Yep.
if you go to a small private practice oncologist, they may not give you the best advice. If you're really suspect, I would talk to a university-based or a big hospital-based oncologist and just get their feeling.
Yeah, and then so let's wrap this up. This was part one, and then part two, we're going to go through FDA approved, well documented screenings that I've done, you've done, and that we recommend and you should do. So we'll do that on our next podcast. But I hope everyone got some insight from this, and like we said, we're here to just help you out, and hopefully we did. So and clarify a little bit.
Right.
All right, it was good talking with you today. That was a really nice one. That was good.
All right. Yeah. And hopefully we'll save some people's lives
Hope so.
because, and like we always say at the end of every show, because when it comes to your health, the truth does matter.
Amen.
All right.
Okay.
So everybody have a great day and thank you for listening.
Take care.